Welcome everybody to our TIF Talk Tuesday. I'm very excited to be here today, and we have a familiar face with us today. But first, I want to introduce myself. I am Andrea Millers with Endogastric Solutions, and today we have our special guest, Dr. Chris Cottrell. So welcome and thank you for being here, Dr. Cottrell.
Yeah, thanks for having me.
Of course. Let me give you a little background of Dr. Cottrell if you don't already know who he is. Dr. Cottrell is a general surgeon at Advanced Surgical of North Texas, located in McKinney, Texas. Dr. Cottrell received his undergraduate and medical degrees from Texas Tech University. His medical interests include reflux and minimally invasive robotic surgery. When he isn't working, Dr. Cottrell enjoys spending time with his family, cooking, anything with the microchip, and he also is the host of the podcast, Dr. Chris, the Surgery Guy. So welcome, Dr. Cottrell, and thank you for being here with us today.
Yeah, no, thanks for having me. It's an absolute pleasure.
Yeah, so if some of you who have followed us and watched our TIF Talks, you might have seen Dr. Cottrell in the past. He's done a TIF Talk in the past with us. In addition to today, though, I wanted to let you know that it is live. So anytime you have a question, please go ahead and type it in the comment section on Facebook, and we will do everything we can to answer your questions. So we thought we'd take it a little bit differently today. Normally we go through and talk about what is GERD and progress onto all the way till talking about the procedure and then life after the procedure. But since we've had Dr. Cottrell in the past, we thought we would do something fun. We are part of quite a few TIF related and GERD related Facebook pages and groups. So we thought that we would jump on Facebook today and ask Dr. Cottrell his thoughts on some of the conversations that are happening and the questions that are coming up on these pages, so he could help these patients that are, have those questions about TIF, maybe bust some myths that are out there. And we'll also do this kind of fact or fiction segment as well. But we'll go ahead and start and pop up kind of what we pulled.
I wanted to just kind of say that,
yeah,
I think this is a good idea because while these Facebook groups, these message boards, they are a great resource for patients, and I would absolutely recommend that patients sort of get involved, kind of get some of the information from patients that have had the procedure. It's a great support group system as well. But doing something like this is really good because unfortunately, occasionally you get someone that maybe heard something wrong and then they sort of start saying that on the internet, and sometimes there can be some falsities that kind of get in there. And so doing something like this where we maybe try and recenter some things can be tremendously helpful. So I think this is a great idea.
Yeah, awesome. And I'm so happy that you're joining us and doing this with us because it's always nice to hear the conversations or see the conversations that are happening.
Right.
But to hear straight from a physician in your opinion, it's good for these patients to hear. So let's go ahead, and I've got it up right now. I've blocked off the names, just in case. But our first question is it standard practice to have an EKG before the TIF procedure?
Great question. And number one, the quick answer is no. But a little more in depth is that an EKG is simply a tool to kind of evaluate the heart, and depending on the patient's age and risk factors, that's really going to determine more when an EKG is necessary, not the procedure that is being done, with certain exceptions that obviously involve heart surgery or lung surgery or something like that. But in terms of the abdominal surgery that we're doing here, there is no need to do an EKG just because. But again, according to your risk factors, age, and things like that, an EKG may be required by either the anesthesiologist doing the surgery, by the hospital, or by your individual surgeon. But for me, I don't routinely get EKGs before these.
Yeah, and I wonder if they're having that conversation because, we've talked in the past about patients having those atypical symptoms when they have GERD and feeling like they're having a heart attack. So it is coming up, or that they were having to get an EKG?
Yeah. So I guess if the question is EKG part of the workup for reflux, again, that also depends. Because if you have a 20-year-old healthy person that has a complete normal story for reflux, I would have no reason to get an EKG if the workup otherwise showed that they had reflux. Now, if you kind of get to the end of the workup and there's not really any reflux being shown, then EKG would be a step as well. But this is where listening to the patient, shockingly enough, can really give you a lot of information. And certainly, if the patient's talking about substernal chest pain that happens after exertion and things sound more heart related, yeah, we need to do an EKG and heart workup. But it really just depends on what the patient's symptoms are, their age, their risk factors. So as a routine, and frankly, I'm sort of an advocate of there really should be nothing that is routine for anything in medicine. We need to kind of individualize treatment based on patients and their symptoms and their risk factors. So for me, no, not standard practice. But I guess as others might disagree.
Yeah, perfect. Thank you. All right, next one. Someone's saying, will it ever feel normal to eat again?
Great question, actually. What I tell people is when we alter, when we take and repair the defect that causes reflux, right? Because ultimately, reflux is an anatomic disease. And so when you take and you cure the reflux but with an anatomic method, short term, there's some tightness. And so patients will frequently not complain, but sort of experience where it's a little bit difficult to get food down. And, we talk about 6 to 8 weeks and it gets back to normal. Often it's a little bit faster than that. And so, yes, it will feel normal to eat again. Now, I joke with my patients a little bit because we do make it tighter than it was before. If they are someone that keeps a spreadsheet of how long it takes to eat and how many chews before they can get it down, and we're really able to track it, scientifically, you might notice a statistically significant difference between before and after, but only someone that does that. There will be a new normal. It will be normal. It won't be something that bothers them. It just might be slightly different than what they had before surgery, if that makes sense.
Yeah, yeah, that's a good point, because she even says here, I was literally wondering if it will always feel weird in my chest. Point.
Yep.
That's what you're talking about, just feeling different.
No, that'll get better. I mean,
Okay.
that's something that I'd be curious to know how long that patient was post-op. Most people feel a little like that for, what will happen is they go on, my patients, they go home on liquids, right? And so once they're home on liquids, the first couple of days, they can't really gulp water necessarily. It kind of goes down a little bit slower. And then by the time they come back and see me, they're kind of just drinking normally and not having any problems. And then we introduce a little bit more solid food, and then they kind of have that same experience again. And then it loosens up a little bit more. Then we add more food. And so by the time we get to regular food, and then maybe a week or two after that, most patients would describe that they are pretty darn normal. And whatever change they may feel is way acceptable compared to the experience of reflux and symptoms they were having before surgery.
Yeah, that's a really good point. Really good point. All right, we've got some questions already popping up, so I'm going to start going quick on the questions. All right. So Derek's asking, what complications have you seen with the TIF? How many TIFs have you performed, and what are your thoughts on links? That's a lot of questions, so I'm just going to sit back and let you answer those questions.
So complications with TIF, any surgical procedure, unfortunately, there is a certain amount of complications and things that can occur. TIF is extremely safe when we speak on the broad spectrum. So, there can be small infections. There can be theoretically a perforation, some dysphagia. And then those are sort of more of and I say dysphagia, that's more of a not a side effect, but back up. Complications. Basically, the big ones would be a perforation or an infection. That's really the biggest thing. It's rare. I've had one out of, I think, getting real close to 300 TIFs, to answer your second part of the questions. In terms of complications, though, a lot of people will talk about complications that I consider sort of normal post-operative course. So short term, you will have some difficulty swallowing or dysphagia. And that lasts, like I said, kind of that 6 to 8 weeks when we talked about the last question. But, that gets back to pretty much normal. Some gassiness is pretty common in the first little bit because when things are tight, you swallow air. that makes you pass gas. But once things get kind of more normal, that gets better as well. So there's a lot of things that are kind of a consequence of kind of repairing things back to normal, and then short term having it being a little bit tight that patients will experience. And depending on how they feel, they might call it a complication, but really I think of that as kind of the normal post-operative course. In terms of severe complications, really you're looking at kind of the perforation and infection being kind of the biggest deal. Fortunately, it's extremely rare. The last question was, what are my thoughts on links? I think links being a foreign body around the esophagus in general, we've kind of shown over and over in surgery that long-term, that's not a super great idea. The esophagus is a very thin-walled organ. It only has 2 layers as opposed to the stomach, small bowel, and colon that have 3. And so it does not really like to be irritated or rubbed or anything like that. And when I say that rubbed, we used to put in synthetic mesh to try and reduce the recurrence rate of hiatal hernias. And those in synthetic meshes would actually rub the esophagus, cause erosions and perforations and things like that. And so I worry long-term that the links, while it certainly can be removed, can cause some of these problems. I know it's wrapped in silicone and that, is relatively more safe, but long-term, I just worry about that. We had the similar experience with the lap band for bariatrics, for weight loss surgery. And, yes, mostly safe. Yes, a lot of patients did really, really well. But at the same time, long-term, it moves, it migrates. Some of them eroded, and now I swear we're taking, a couple bands out every single month in our practice now. Well, maybe not maybe one a month for the whole practice. So, long story short is those kind of have failed over time. So for me, I don't like foreign bodies that sort of encircle the esophagus and can cause theoretical problems with either dysphagia or perforations or erosions.
Okay. We're going to go ahead and ask the next question, then we'll jump back to our Facebook questions. So Corlene's asking, my Bravo test showed I have acid reflux, but my pH level is normal. What does that mean?
My Bravo test says I have reflux,
but her pH level is normal.
I'd have to look at that study. The Bravo studies is for those that don't know, there's a little pill that gets implanted at the distal portion of the esophagus, and then it measures the pH. And it's really cool because what happens is you can literally, it comes with a little like beeper thing, and so you go home and this thing, the little pill thing falls off. But basically, whenever you have symptoms, there's like a couple of buttons you can hit, and then it correlates with kind of what your pH or whatever is doing at the time. And when you look at the pH probe, typically if you're saying you have acid, you feel like you have acid reflux, and you hit that button, and then then we correlate that with sort of what's exactly the pH of your esophagus is at that time. So my suspicion is, and I'm kind of guessing without looking at the study, is that while the overall pH might be normal, or pH might be normal when you average it out, individual episodes of reflux and acid reflux and low pH are actually occurring. So if it says you have acid reflux, my suspicion is that you do have acid reflux, but for whatever reason, that pH kind of didn't average out to being acidic. Got it.
Okay. We got another question. If you have a lap band, are you able to get the TIF?
No. That's pretty easy. Unfortunately, the lap band is literally right in the spot where we would be doing any kind of wrap. So if the lap band is doing well, then that's going to be a problem. Now, interestingly, if you're having reflux with a lap band, there are other solutions. Frequently when the lap band migrates, reflux is one of the first symptoms. So, looking at that and sort of looking at an X-ray study or a swallow study to see what the lap band is doing may be more important than considering reflux surgery, because either repositioning the lap band, removing the lap band, that may be more appropriate than any kind of anti-reflux surgery. So I would definitely investigate that. Furthermore, once the lap band is removed, then yes, you could go in and have anti-reflux surgery, traditional or the TIF. Yeah.
Perfect. Awesome. Okay, we're going to jump back to our Facebook groups. And here we go. Officially 5 weeks out and still feel like I have symptoms, starting to lose hope
So let's see, something coming.
Yeah, people are saying mainly just the sensation of something coming up in my throat. No
So
heart
this is,
normally. Yeah.
yeah, this is something actually Dr. Glenn Idy and I talked about on the podcast a little bit. And he and I have kind of two, I don't think they are mutually exclusive points of view. And I don't want to answer for Dr. Idy, but I think as I understand it, when your esophagus is sort of contracting and pushing through what is a very loose area that causes reflux. So the junction between the esophagus and the stomach, when it's very, very loose, it's pretty easy for stuff to go down. So in his estimation, sort of the esophagus becomes quote unquote lazy. And so then when you make everything fairly tight, the esophagus doesn't contract all that great yet and has to sort of exercise and get stronger before it can really overcome the area. And so what happens is that the food sort of bounces, in my estimation, bounces down between the gastroesophageal junction and then comes back up. And so again, not mutually exclusive, but I think of it as not gastroesophageal reflux, but esophago reflux. So stuff from the bottom of the esophagus coming back up just because the GE junction really is a little bit on the tight side. Your esophagus isn't contracting well to get it through. So sometimes patients will be like, well, yeah, it doesn't burn anymore, but I still feel like stuff comes up. And to me, that's a great symbol that, it's not really coming from the stomach, because coming from the stomach, it should burn. So if it's just coming up and not burning after a TIF or a hiatal hernia even, then that kind of tells me that they're sort of experiencing this phenomenon of either lazy esophagus or esophago reflux, as I call it, where again, that stuff just kind of bounces back and forth. And then once things open up, generally it starts to go down and get much, much better.
So these people, just it takes a little bit more time for the sensation.
Well, yeah. And then, unfortunately, it's a little bit vague. 5 weeks out, still feel like I have symptoms. I've definitely had stuff like that. See, yeah, when the follow-up, mainly just sensation of something coming up my throat, no heartburn really. When my female symptoms are proved, they're definitely not gone away yet. And, I bet you that's exactly what they're experiencing. So just literally a matter of time. And if you question that patient, I'm wondering if they're maybe still eating a little too fast, maybe a little bit too aggressively. And it's sometimes just backing up a little bit will kind of let things go down and improve those symptoms. But that means sometimes it could be too tight. It's also possible that, the TIF just wasn't made quite tight enough. And it might need to be adjusted. But in general, I bet you that's just going to get better.
Awesome. Okay, great. All right. When are you able to drink post-op? So someone,
as soon as you wake up.
I know. Someone wrote, my guy said at 6 weeks, but no bubbly stuff. So I'm wondering if they're talking about alcohol, or are they talking about, it sounds like alcohol. It sounds like alcohol.
Sorry. I do not prescribe bourbon right after surgery. In terms of alcohol, honestly, that's a risk-benefit thing. Generally, I would recommend that we don't do anything for the first week, just while everything's healing from the TIF itself. You could get some really more symptoms than actual problems. Just it would burn and might cause some discomfort. Beyond that, carbonated beverages in the first 6 weeks are definitely a no-no. That'll give you a lot of excess bloating and gas. But if you wanted to have, a martini or a bourbon or whatever, generally after a week, you can have a little bit of that, as long as you're off the pain medicine. Don't want to mix alcohol and pain medicine. That is not a great idea. Narcotic pain medicine.
Good point.
But once you're off that stuff, I mean, have a responsible adult beverage. I'm all for that.
Awesome. All right, this one to the right of it. How do you know if you've injured your TIF?
So, that's interesting. I'm not sure what that means. The quick answer is reevaluating. You'd have to look at an EGD to look at the actual TIF and the construction of it. An upper GI may be helpful. Newer technologies like the EndoFlip, which is sort of a pressure monitoring of the distal esophagus, may be helpful as well. But basically, if we're worried that the TIF has been disrupted in some way, shape, or form, frankly, you'd have to have it reevaluated by a physician and sort of medically.
Okay. And it also depends if they had a hiatal hernia repair as well too, right?
Yeah, but the answer would be the same.
Yeah.
You still have to have a full evaluation.
Right. Okay. So next one, is it true that we can't throw up after the TIF?
Short term, yes. Long term, no.
Yeah.
So we mentioned this just a second ago, but basically when we tighten up the area, and tighten up the area is a sort of a loose way of describing sort of recreating the appropriate anatomy and reflux barriers. But in effect, after surgery, the area does get a little bit tight. And so short term dysphagia, problem swallowing, and then it is tight enough that some patients will have some difficulty with burping and throwing up. That being said, that usually gets better again in that first 4 to 6 weeks, maybe out to 8, but that's about it. And then that usually is not a problem whatsoever.
Perfect. All right.
And in direct contrast to patients with a Nissen, the traditional wrap where you take the stomach and wrap it around the esophagus, if you think about it, when your stomach contracts to throw up, then the Nissen is actually going to contract too and actually shuts it down even harder than it was shut down before. So with a true Nissen, throwing up is almost impossible unless it's very, very loose. And then you walk that fine line between, is it loose enough that it's going to cause reflux, or can you throw up? And there's like this tiny, tiny little line that you have to sort of walk on that seems like it's either too loose or it's too tight, and it's a little bit tough. That's one of the big advantages of TUF, is that middle line gets much, much wider. I lost you.
Nope, I'm still here. Can you hear me? Sorry. All right, next one. Let's go. Does anyone else here? So they're asking for other patients, but it'll be interesting to get your thought on this. Does anyone else here wake up in the mornings belching and passing gas every day? I feel so bloated and gassy every morning. I'm not even hungry or anything in the mornings because of it. I have a GERD healthy diet too and don't eat late. Just wondering if others deal with this. Is this common for them to have?
Yeah. So it's interesting, the gassiness and passing wind, if you will, or flatus, whatever you want to call it, sort of correctly. But the problems, it's interesting to me because preoperatively, one of the defenses that your body normally has for reflux is that you'll swallow, right? So if you feel that stuff's coming back up into your esophagus, your natural mechanism to get rid of that is to swallow. So you swallow, and every time you swallow more air. That air has to go somewhere. So you're either going to belch or it's going to come out the other end. And so that's kind of a relatively normal thing. People that have a lot of reflux often are a little bloaty, a little belchy, and a little bit gassy. So that's part one. Then part two is after surgery, you also see sort of kind of the same thing, because now it's a little bit tight. Okay. Again, that's kind of loose term for restored anatomy, but after surgery, a little bit tight. And so when it doesn't quite go down, your body's natural mechanism is to swallow. And so you swallow more, you get a little bit bloated, a little bit gassy, a little bit passing gas. And so it's kind of the same exact symptoms. So I've had patients that one of their biggest problems was exactly this. And I have to be very, very careful to warn them that right after surgery, they're going to experience the exact same thing. And then once all that healing happens, then it'll get better. So it's not an immediate thing. Whereas the reflux goes away almost immediately. The heartburn goes away almost immediately. But in terms of the gassiness and the bloating and some of the belching, that actually takes a little bit more time. So yeah, this is a normal kind of thing of, someone who's had reflux all night, they were swallowing while they were asleep, then they wake up and they're burping and they're passing wind, pretty common. So even a GERD healthy diet, and yeah, I certainly recommend that. And I post that on the Instagram all the time where we talk about foods to avoid and triggers to avoid and things like that. And there are foods that do that. Even with that, the mechanism for reflux is still there. And so that'll only help so much.
So your patients like that patient that you were just referring to, how long did it take for him or her to not have that sensation as much anymore after the?
Yes. Usually it's it's kind of that 6 to 8 weeks, and everyone's a little bit different. Sometimes it's a little bit faster, sometimes it's a little bit slower, but that's the general rule. Patients well warned, and I think as a physician, and to the docs out there that may or may not be listening, when you're talking to your patients, the more you explain to them, the more they understand, and the less dissatisfied they become. I know it's a double negative, but basically, the more you explain to them in advance, the more that they understand when it does happen. And I think that's one of our biggest sort of downfalls, is we sort of forget some of that stuff sometimes. So the more you explain some of these things that are more bothersome, the better patients do. Because when you're told by your doc, hey, you're going to be gassy, and then I'm a little bit on the joke side, because I think that relieves tension. I kind of talk about, like, play games, do the pull my finger game with your kids or whatever, and have some fun with it, because otherwise it's normal and okay.
Yeah, I like your the set expectations as a physician to your patient. I think that's great. All right, this one. It almost sounds like people in here are saying you need to be more careful post-op than a Nissen. What is that about? Can't work out for how long? So it sounds like, people are talking about the difference between post-op TIF versus a post-op Nissen.
Realistically, when you're looking at a TIF that is an intra, inside the stomach repair versus a Nissen that's, this outside repair, honestly, even though they're different, they're similar in some ways. And so you don't want to disrupt either one. And so frankly, it's kind of the same diet, exercise routine, all that for both. So if I have a patient that for whatever reason couldn't have a TIF and we did a traditional Nissen, frankly, it's almost the same thing. And I'd probably give them my sheet and cross out the TIF, and, it's the same deal. So, because, you're still talking about a repair, you're still talking about something that doesn't need to be disrupted, you're still talking about tightness. So it's a lot of the same things, just with the Nissen, it's longer. That's the big problem, is like with a Nissen, it's, you're talking about that 6 to 8 weeks. I mean, with Nissens, a loose one that maybe doesn't work as well might be 6 to 8 weeks, but I've had patients that it was 6 months to a year before they got back to truly normal food. So, honestly, with food, you have to be more careful with the Nissen. In terms of post-operatively, in terms of running and lifting weights, those are basically the same recommendations. Run as soon as you feel like you can do it. No lifting over 20 pounds for 6 weeks, at least for my patients. And that would be for both.
Interesting. Okay, good. Okay, how many of you had TIF and had no idea what was causing reflux? No hydrohernia or obstructions. Hold on, let's see what are they all talking about? 4 weeks post-op. This one's kind of just a comment. I'm gonna skip that and go to the next.
No. We can talk about this actually. Okay. I think if you go back, So I think the important question here is, before you were decide to have surgery, if this was my patient, I'd be recommending, frankly, just more workup, because if they actually have reflux and no hiatal hernia is identified and there was no other sort of thing, you've got to make sure there's actually reflux. So that's the patient that would need a Bravo probe. That's the patient that would need endoflip or manometry type studies. Gastric emptying problems can cause reflux. So there's a lot of other things that can cause reflux besides just a hiatal hernia, although that's the most common cause. So more workup is warranted. And, it's a comment, obviously, so it's just a question of, like, how much workup did they actually have, and what else needs to be done. But to me, that's a perfect example of just someone who needs to be evaluated further.
Right. That's a good point. Really good point. All right. This one's the same. How long did it take for the awful gas to go away after this person's 8 weeks out, and talking about gas X? And so
now,
but
this does bring up a good point, because there are patients that kind of get to that 8 weeks and are like, all right, Dr. Cottrell, you said 8 weeks. I'm still a little bit bloated. I'm still not eating bread, and I'm a little bit frustrated. Yes, my reflux is better. Yes, I understand. But when is all this going to get better? And, with some patients, for whatever reason, everyone heals a little bit differently. Everyone scars a little bit differently. And so I've had patients that, we talk about 6 to 8 weeks, but I've had people that it was longer. I have. I haven't really had anyone really go past 12 weeks that I can remember, at least offhand. But basically, at some point, we start talking about there are options, right? This can be sort of dilated a little bit. If it just got too tight for some reason, there are things that we can do. So just because, they're 8 weeks out, it doesn't mean they need to have a procedure, but that's the time when I might start offering them a little bit of kind of, okay, we still want to wait it out, because anything we do could jeopardize the actual repair. And this should get better, but we have options, right? A lot of people talk about, the TIF not being completely reversible, and it would be difficult to fully reverse, but there are things we can do to mitigate. If there was a hiatal hernia repair, we can potentially loosen that up. If there was, some sort of scarring, we can actually do some scar tissue revision. Steroids can be helpful in this scenario as well. And, finally, we can actually dilate. So I start offering these things when patients sort of start getting a little bit frustrated. Most of the time, honestly, we don't have to use them. It just kind of gets better on its own. It's just waiting it out. So
yeah. That's a good point. I'm glad you mentioned that. I get questions about that all the time. Can it be redone? What happens if it doesn't work anymore? So on and so forth. So, okay, this one's funny. Silly question. Does anyone know if you can play golf after 6 weeks?
Yes.
All right, that was an easy one.
Yeah, no, 20 pounds, 6 weeks. After that, you can do whatever you like. So whatever that includes. Actually, depending on how competitive the golfer, I will let them play golf just a little bit at about 3 weeks, but they can't lift their clubs because that's more than 20 pounds.
Oh.
And then not competitive golfers, kind of just someone who's going to be out there and just enjoying the outdoors and, swinging a club every now and then, because in my mind, the swinging of the club is not really the same thing as lifting. Although I would bet you there are people that disagree with me. I bet you people would disagree with me about that. And that's fine.
Okay, I'm on day 6. How many days until my chest stops hurting? I had a hiatal hernia repair and gallbladder removal at the same time.
4. This is something that's different with every patient, unfortunately. When we're repairing the hiatal hernia, when we're doing a TIF, there is some pain that happens, and it can actually be scary. I still admit my patients overnight, because that night the pain that you do experience, although not extreme, is right here. Okay, it feels a little bit like your chest is heavy. It's a little bit harder to take a deep breath, and when you Google that, it goes right to heart attack and go to the ER. So to keep people sort of grounded, we talk about that beforehand, like we said, managing expectations. And so most patients aren't really bothered by it when they know that it's going to happen. But if we need to, we you get EKGs and work it up as needed be. Most of the time, honestly, usually in my experience, it gets better in the first 2 to 3 days. Day 6, if it's just in chest pain, it's kind of different. Are they having pain when they're breathing? Or are they having just sort of a constant pain? If it's pain when they're breathing, I know that can take a week or 2 for sure. Pain from the actual sort of TIF and or even hiatal hernia repair, that usually gets better in 3 or 4 days. So if you're at day 6 and it's just constant pain, that's something I would definitely talk to my physician about. That could be a sign of some sort of injury or something that's not quite right. But if it is just kind of, it's a little bit tight when I take a deep breath, and that is more normal, and that takes about a week or 2.
All right. Okay, let's see. So if I had a Nissen in the past and it is loose now, am I still a candidate for the TIF procedure? I'm looking at the one on the right.
Yep, I see it. Absolutely. Yeah. I literally did this morning.
Wow.
Basically with a Nissen, when there's recurrence on the Nissen, almost always it's the hiatal hernia portion that's recurred. And so when you look at hiatal hernias that recur, the wrap is usually fairly intact. So it is usually not necessary to actually do a TIF procedure because the wrap's already intact. And we don't want to make something tighter and then give them dysphagia. Usually it's a matter of repairing the hiatal hernia again. That being said, if it is the fact that the Nissen just was never tight enough, or there is not a hiatal hernia, a Nissen, and I've done this several times, you can do a TIF on top of a Nissen, and actually it works really, really well. So yeah, something to be evaluated. A TIF may not be right for you depending on what your anatomy is, but certainly it would not preclude you from having a TIF.
Perfect, thank you. I think this next one's good. It's a little bit longer, but so I do not get food coming up or burning in chest, some hoarseness, not feeling in mouth at night. Upper endoscopy says Barrett's esophagus. I eat 3 hours before bed and have the head of the bed up. I have irritable colon, mostly constipation. I think the heartburn, in quotes, is connected with the constipation. Could that be? Is there treatment for Barrett's esophagus?
Yes, there's a treatment for Barrett's esophagus. It depends on what stage you are and if there's any sort of precancerous cells in that. A lot of times Barrett's is just monitored. high-grade Barrett's or Barrett's that starts to turn into something that it could be a malignancy, can be either resected with the mucosa, and then that regrows normally. It can be ablated with radiofrequency ablation. There are several treatments for Barrett's esophagus, so that can be treated. Now, that being said, I think the overall gist of this post is something that they kind of think their reflux is more related to their constipation, and they're not really sure that they even have reflux, but then they also have Barrett's. And I can tell you that if you have Barrett's, frankly, you've got reflux that's fairly significant. Is your heartburn related to your constipation? Possibly, although it would have to be pretty bad constipation to back up that far. I think, that's something obviously you want to evaluate it. There are many different ways to evaluate, and everyone kind of does this just a little bit differently. But things like upper GIs, endoscopies, I've mentioned EndoFlip a couple of times that talks about sort of how well your esophagus contracts and measuring the pressure as the esophagus goes into the diaphragm. And so getting a workup, that's really the answer. In general, it's not a great idea, and this kind of goes for all of medicine, but if you're at home and you're wondering about something and then you start trying to come up with rationalizations while you feel a certain way, go see your doctor, right? I mean, there are lots of things, you don't want to start making these assumptions and then come back later and realize that your Barrett's actually turned into adenocarcinoma of the esophagus, or that you actually had a big giant stomach mass or something like that. Go see your doctor, get it worked up. And then if you don't want surgery, great. You can control with medications if that works for you. But in general, with someone that has a history of Barrett's, I would definitely get that reevaluated.
Perfect. Thank you. We've kind of answered the other questions. So there's a couple of questions on Facebook that have come up. So I want to get to those. We've got Barb asking, I've been on an antacid for a long time, years. I'm getting, why am I getting sick right after I eat?
I've been on antacids or proton pump inhibitor. What did you say, antacids?
She said an antacid, but not PPIs.
So it kind of depends. Some people get a little bit nauseated with some of the antacids. So if they're actually chewing, whether it be Tums or Rolaids or any of the name brands or even off brands, that can cause nausea depending on how many you have to take. So that can cause symptoms in and of itself. And then, frankly, there are a multitude of reasons that just kind of need to be evaluated. And endoscopy is certainly a good start, and other things as well. But trying to figure out what's causing your nausea right after you eat. I mean, heck, that can even be gallbladder symptoms. So there's a lot of overlap there, and without a little bit more information, a little bit difficult to answer, but it really sounds like, possibly an ultrasound, possibly upper GI or EGDs or the EndoFlip like we talked about. But yeah, lots of people get nausea right after eating. That is a little bit more associated with like gallbladder type symptoms, in my opinion. But again, without actually talking to the patients face to face, very difficult.
Interesting. Okay. Derek's asking another question. How is the TIF for regurgitation symptoms, and what is the diagnostic testing for achalasia? I'm making an appointment with you soon. Also, FYI, LOL.
Great. So
that's what he said.
Yeah, no, that's great. So lots of questions there, but basically with achalasia, there's two basic tests that sort of, that is the best diagnosis for achalasia is something called a manometry, and that's a pressure study of the esophagus. And that sort of can tell if there's a big giant pressure gradient across the esophagus, then that's what achalasia looks like. And that's treated completely differently, and a TIF would be inappropriate there. You can also get a good idea with a upper GI where you just drink contrast. That usually kind of comes down to an actual point. And that's got a fairly characteristic look on the upper endoscopy. And I've mentioned it several times, I have no affiliation, but EndoFlip technology is something that you can get pretty good information and a really, really good correlation and not diagnose achalasia that way. And that's basically, it's like manometry. It's not as extensive. It only measures a certain area, but it can be done at the same time as EGD or endoscopy. and very, very convenient. And right now, it's got a very high correlation rate, so it can diagnose achalasia as well, but it's still a little bit on the newer side. So a lot of people still confirm that with manometry. What was the other part of the question? I don't think I answered everything.
That was it. He's just saying he's making an appointment with you soon, so he's going to see you soon. He must be in Texas area. Which is great.
Very good.
Okay. It looks like we have one last question. If you're on and you have any questions, please type them in. But this one's from David. He's saying, I have bad acid reflux, GERD, and have had it for years. I take acid reducers, but they only help a little bit, and I still take Tums as needed. Could this resolve my problem? I'm assuming he's asking, could TIF resolve his problem?
No, absolutely. Obviously, in terms of evaluation, everything has to be evaluated. You can't just completely diagnose via a post. But when it comes to someone like you that is on medication, that is one of the main indicators to consider surgery. And so that's something that if you're not doing well on the medications, that is, even some of the people that aren't as big on surgery for reflux, those are the people that still get referred to this day. So definitely someone to consider for reflux surgery if you're not doing well on the medications.
Perfect. Wonderful. Well, that's all the questions we have tonight, Dr. Cottrell. Are there any last comments or anything you want to say to these viewers that are watching that are suffering from GERD or need more information?
Sure. I think honestly, it's more a comment of kind of what we talked about at the very beginning, is that go to these Facebook posts or message groups, Reddit, whatever, and get support, and talking to people that have had it. That will be very, very helpful. I've actually had patients that came to me sort of via these groups. But ultimately, when it comes down to your body and your medical decisions, you need to see your doctor. You need to see someone that has a specialty. If we're talking about reflux, specialty in reflux, and get sort of the straight answers. Taking medical advice from a Facebook post or a Reddit post or some other post can be fraught with a good danger. If you got a simple thing, hey, when's this gassiness going to get better after surgery? Post-operatively, it's good support, but pre-operatively especially, be very, very careful, and don't assume that just because someone else had your symptoms and did well with this, that your symptoms could be related to something completely different and potentially even more dangerous. So please take the information, take what you need out of it, but at the same time, go see your doctor, go see your reflux specialist. And that would apply to everything in medicine. So don't rely on Facebook groups or anything like that to make diagnosis. That would be not a great way to go.
So with that said, there's questions as to what doctors you see if they're suffering from reflux. Now, you're a general surgeon, right? So sure. Could they come and make an appointment with you directly? Does it just depend on insurance? How does that normally work?
Yeah, absolutely depends on the insurance. When it comes to reflux, a lot of people come to me via avenues like this, Facebook. I think Derek is coming to see me. I'll look forward to that. But when it comes to, so a lot of people sort of self-refer, and that actually comes, this is gonna be a longer answer, sorry.
Oh,
but
you're good.
That actually comes from some frustration where there's a lot of people that think that taking a proton pump inhibitor or an antacid or anything that can sort of control the symptoms of reflux is sort of the cure. And sometimes we differ from that with other doctors who, we feel like anatomic problems require anatomic repairs and surgery. And so while surgery isn't right for everyone, we have to admit that sort of pills aren't necessarily right for everyone either. And, the answer is probably at least somewhere in the middle. But so what happens is the patients, not unlike the last question, it's possible he or she bounced it back and forth and just kind of kept going, here's more pills, take this, you'll be fine. And then they're just kind of like, I'm still having heartburn, I'm still having all this stuff. And so then they get a little bit frustrated. So it just kind of depends on what kind of traction you're getting with your doctors. So PCP is always a good place to start. Most insurances at this point, they require referrals anyway. So at least start with your PCP, and you want to get the basics checked. You want to get your thyroid checked. You want to get everything kind of checked and all that, just to make sure there's not a very easy sort of medication that you can take that would control that. And then at least get started on something that may control your symptoms. So PPI to start is not a bad idea. And then often those patients then get referred to GI. And then if GI is someone that either has a relationship with a surgeon or kind of believes in sort of anatomic cures, then you may have sort of an easy path, or you can get kind of stuck in this loop. And so advocate for yourself. So if you're kind of getting stuck in the loop, ask, hey, is there something else that can be done? Is there another way that we can go? I'm kind of tired of taking these pills, or these pills aren't working for me. And then that's a personal decision between you and potentially the surgeon or someone else that might be considering a procedure. My goal always is to educate and kind of help people make a decision. And if they choose to kind of go on and take pills, hey, when you change your mind, we're here for you. Otherwise, best of luck. Please make sure you get them reevaluated every couple of years, that you're not developing Barretts, and we give that advice as well. But I'm not here to talk everyone into surgery. I'm here to give the information that we can.
Yeah. Yeah. And at the end of the day, that's the whole reason why we started doing the TIF Talks, is really to let everybody know there's not a perfect solution for everybody.
Nope.
And I think most physicians would say the same. It's personalized. You take a personalized approach to your treatment depending on what you're suffering from. So our goal is just to come out here and give you some information, let the doctors talk, answer questions, and but to your point, I think that's the biggest, leave behind here is advocate for yourself, right?
Sure.
There's other resources out there. There's other things that you can do. You don't have to always keep suffering. So
sure. And speaking of other resources, you mentioned at the beginning, I'm just going to do a shameless plug here. You can go to Dr. Chris, the surgery guy. You can listen to that on Apple Podcasts, Spotify. I think we're on Pandora now, and a couple other places. But yeah, we go over some of these things and other interesting surgical topics as well. And there's more information there, and there's other doctors that do that as well. There's also an Instagram where you can get more information at Chris Cottrell MD to get additional pieces, and we put stuff out all the time, kind of giving you more and more information daily.
Perfect. Thank you. And then for anybody that's looking for a physician that does the TIF procedure, you guys can go to gerdhelp.com. There's a physician finder in there, and you just put in your zip code, and you'll be able to find some physicians that are in your area. And if you're in Dr. Chris Cottrell's area, the North Texas area, you can go make an appointment with him, like Derek did.
So, I do want to say that one of the questions that we got today was how many, and I think that's a very good question. You want someone that's done this. Everyone has to sort of start somewhere, and so even if they're starting to do their first TIFs, you at least want someone that's done a lot of reflux surgery and understands the principles. And those are good questions to ask. So many times a PCP refers someone to someone, and you assume that there's this great relationship and they're friends and they understand each other and everything like that. And that isn't always the case whatsoever. So ask the questions, advocate for yourself. Don't be afraid to say how many have you done, or is this something you do all the time? Most surgeons shouldn't have a problem answering that. If they do, somewhere else.
All right. Well, thank you again so much for being on our TIF Talk tonight, Dr. Cottrell. We really appreciate it. I know patients probably appreciate it as well. So everybody, thank you for joining us tonight. And you can catch us every Tuesday for our TIF Talks. Everybody stay safe, and thank you, and have a good night. Take care.
Take care.